thank you for accepting our invitation to moderate the session on perspective management of treatment transfer in the transforming the treatment paradigm for patients with relapsed or refractory ALL in adult B-cell particularly. So since there is a lot of changes and treatment in the protocol has been observed, and to discuss further about the expert to talk on this and to gain the rich experience, I welcome Dr. Sushil Selvaraj, Associate Professor, to add value to the sessions. Also, I welcome the Dr. Steve Thomas, who is an Associate Professor in SRMC, who is a consultant hematologist, and also I welcome Dr. Sudeep CV, who is also a consultant hematologist from Aster Med Hospital. Thank you very much for accepting our invitation. And with further ado, Doctor, I will hand over the session to Dr. Sushil Selvaraj to take over the session, sir. Over to you, sir. Thank you very much.
Thanks, Santosh. Am I audible just before I start?
Yes, sir. It is audible, sir. You're audible.
Great. So, good evening, everyone. It's my pleasure to moderate the session with two eminent faculty like Dr. Steve and Dr. Sudeep. As was introduced before, they are eminent hemo-oncologists in Chennai and Kerala, respectively. We'll go on to the session. This is, standard disclaimer that this is my opinions, and I've made sure that I have not toed any company line. So we'll start off with two questions before we get into the meat of the presentation. I'll probably talk for a few bits of the presentation, but I really want it to be interactive, and I'll be happy if anyone stops me in between or at the end. So with those things out of the way, the first question I would like to probably just get a ballpark estimate of how many patients you all see for adult ALL in a year, and what proportion of those are relapsed ALL in your setting. I will start with Dr. Sudeep.
Yeah, adult ALL usually we see less. As of now, a new setup. So I think around in the last year, I would have seen maybe around a dozen, and actually a good proportion of them were relapse refractory. So new cases are a little bit less comparatively. So that is what is there for me. Yeah.
Sure, that's helpful. And, Dr. Steve?
Yeah, around 20 to 30 cases in a year. And
Steve, we missed the first half.
Yeah, around 20 to 30 cases in a year. That will be the ALL patients. That will be including T and B probably. And refractory and relapse will be almost, I would say, 50% of them. Like half of them might be relapsed and refractory. As of now, we are not getting referrals for refractory straight away, but we do have our old patients who have relapsed or refractory, and those patients are on treatment as of now.
Oh, that's interesting. Why do you think they're not being referred to? Just as a curious.
I don't know. I think after the first relapse, usually I think the number of the patients who are unable to afford, I think they are not able to come because of that. And the patients who are able to afford, I think they go to some other private centers probably. That might be the reason, I think. So the patients who come primarily are newly diagnosed ALL cases for in our center at least. Yeah.
Sure. Okay, that's I think an interesting thing, and pretty much this is old data, of course, but relevant data. Just to know from where we've come, these are the outcomes after first relapse back in 2007 from large clinical trials that were large studies that were had collated data from ECOG, UKLL studies, LALA 94, all showing sub 10% outcomes in after first relapse in ALL. And very important prognostic marker was the response to the salvage. And as you can see here, the patients who achieved CR had a much better overall survival compared to the patients who did not achieve CR. And this was significant over the board in all studies. This is some good data that will just give you sort of ballpark estimates, ballpark figures of where we stand. As you can see here, these are the various trials, PETIMA, some of the Western countries. We know that from, I think there was a fairly good and comprehensive review of the data that was published in Clinical Lymphomyeloma in 2020. And that looked at multiple centers from India where anywhere between 7% to 55% plus This was the proportion of ALLs that were diagnosed, and the CR rates, as you can see, were all sub 50% mostly. The overall relapse rates were again hovering between the 24 and 57%, but of course this was given the unhomogeneous nature of the treatment that goes on in India. Unlike the Western countries, these sort of fluctuations are to be expected. These are few of the important studies, large cohorts, a few is from, lots of them are from CMC. And as you can see here that in the relapse cases, the predominant, the large number of patients, as Dr. Steve and Dr. Sudeep had mentioned, went on to palliative modes, anywhere between 78% upwards. ALL cure rates decreasing with age is a well-known phenomenon, and this has been borne out across the decades of treatment despite the overall improvement in outcomes. The rationale for therapy in ALL, the rationale for treatment, as we know, for this sort of behavior in adult ALL is inherent chemoresistance, a higher treatment-related mortality, especially in the older populations. All these are the issues that plague adult ALL, but also the higher incidence of high-risk mutations, and therefore there is a hypothesis that there will be improved response when there is an increased use of the salvage regimens upfront, which was suggested back from the early 2010s onwards. And recently, over the past 5 years, studies in this regard have come out. We'll be discussing a few of them. What makes an ideal therapeutic target in ALL? Favorable antigenic features like high antigen density of expression, lack of expression on normal cells, and the high percentage of blasts expressing the antigen. Of these, the targetable the current dominant targets that we have known previously, CD19 and CD20 for mature and precursor BALL who express CD20 and 19. And of course, recently CD22, where we'll be talking about the drug of the hour, which is inotuzumab ozogamicin. And just a small note on inotuzumab ozogamicin. I think most of the audience will be aware that it is a linked antibiotic linked to a toxin, where the monoclonal antibody, the monoclonal antibody is linked by a actually fairly non-toxic linker compared to gemtuzumab, the AC-but linker, which, however, even though it is fairly non-toxic, we will be discussing some of the toxicities that happen. And of course, the highly toxic calicamycin derivative, which is linked onto the onto the monoclonal antibody. The advantage of CD22, besides all the standard, we know that CD22 is one of the cell markers of mature B cells, and it is also highly expressed in patients with BALL also. And this, therefore, it is not expressed on hematopoietic stem cells. It is not shed, which is another important aspect of the specificity of and the low amount of off-target toxicity. The CD22 molecule is not shed off the cell, and the inotuzumab itself binds to the CD22 on the cell surface, and then the calicamycin is internalized and released within the tumor cell. We know how potent it is in comparison to other chemotherapeutic agents, which is why it cannot be given non-targeted. And then it acts pretty much like any anthracycline. It causes a double-stranded DNA break along the minor groove, and then subsequently apoptosis of the tumor cell using the standard apoptotic pathways. Another interluding question, which is the diagnostic testing that you use at your centers for establishing a diagnosis of ALL, and whether CD22 is part of your initial panel of diagnosis and a panel of your relapse. We'll start with Dr. Steve.
Dr. Steve, yeah.
Yeah. So the routine test that we do when ALL, basically BCBC, look at the peripheral smear, look at the blast and tumor lysis profiles, spiral markers. And for the diagnosis, we do a bone marrow aspirate and biopsy, followed by a flow cytometry. And once the ALL diagnosis is made based on flow, then we send risk stratification, that will be karyotyping, and genetic and fish also can be sent ALL fish. And in our center, we do a 10-color flow and CD22 is included.
Very good. Dr. Sudeep, any additions or anything that you avoid?
Going for the same only, a bone marrow
Sure.
aspiration biopsy, a karyotyping, and an ALL translocation panel, and a flow cytometry, which will include CD19 and 22, definitely.
Is there anything, any test that you do more in the relapse setting rather than the new set at first presentation setting in new ALL, newly diagnosed?
In the relapse setting, karyotyping, I mean, any new test, if you're asking, then I think no, particularly not. Very rarely, in a case of family history of cancer, I sent an NGS panel with 133 gene and I had found TP53 positivity. And that was it. I mean, that had a germline positive was there in the other family members also.
Okay, so
That
you
had
do a
found,
germline testing in some patients.
that was one rare instance in which we had gotten that.
Sure.
I mean,
Are either of you doing an next-gen sequencing at any point for ALL?
this one only, this NGS only was done for the relapse one.
Yeah,
That was
no, I
NGS.
mean, besides germline testing, are you looking for any other mutations in ALL using an NGS panel?
As of now, no. But
Dr. Steve, are you using anything?
Not routinely sending NGS for these patients.
Okay, sure. So pH
For
like
AML patients, if the affordability is not an issue, then we send for ALL patients. For AML, we are sending just to see whether any of distinct targetable genes are there, just in case that can be added, therapy can be added.
Sure. So I think
not routinely sending for pH like ALL translocation, CRLF, all that we are not sending straight for all patients. Yeah.
Fair enough. That I think that's so both our panelists have fairly comprehensively covered the initial diagnosis of ALL, and there's nothing more to add there. I suppose the poor prognosis problem. I mean, we've already gone through the issues with our ALL relapse setting. This is a brief look at the NCCN guidelines. While these are far from ideal guidelines, given that they're heavily insurance driven, what is striking is the quick upcomments in relapsed refractory disease within a few years of approval for both blinatumomab and inotuzumab ozogamicin. As you can see, both in the pH positive and pH negative ALL settings, relapse settings. They're also now slowly entering newly diagnosed, which we will discuss a little on down the road. And all this was based on the landmark Innovate trial, which, as you can see, I'm just going to go through a few of the time points because a lot of our discussion and our understanding of the doses that we use, the toxicities that we have to look for is from this trial. And so just a brief note for anyone, I think it's good that we look into this trial in detail before we go on to the next points, which is the trial started recruiting and completed the CSR cutoff in October 2014. The last patient was randomized by Jan 2015. By March 2016, the primary OS data cutoffs were achieved, and the data was put out in an NEJM, famous NEJM publication in 2016 August. And subsequently, the longer term analysis have been coming out every year. One of the big ones was the 2019 Cancer publication, which looked at the long term analysis time points, all from with the lead author being Dr. Kantajan from MD Anderson. And as you can see here, more than 18-year-old patients with RRALL CD22 positive were chosen. Important to note here, I think, and something that will stand out as one of the critiques of this study was that the SOC here, which is the standard of care, was the flag, Aracine mitoxantrone, or Hydac, which is not really classically what we use in India or what is used abroad as standard of care in relapsed refractory ALL upfront setting. This was, and in the main arm, the inotuzumab arm, you can see 0.8, 0.5, 0.5, the doses that we use currently, day 1, day 8, day 15, and they were this was on a 1:1 randomization, looking at the two primary endpoints of CR and OS. And we breeze through the baseline characteristics fast. Going on to the treatment response and molecular remission, as you can see here, this is what it showed. 80.7% versus 29.4% in the standard of care arm, and significantly higher MRD negativity in the responders as compared to the standard of care arm. the other important thing was that it's important to remember that the response, even in subgroup analysis, maintained their significance. That is, even in patients which had large load of disease, that more than 50% bone marrow blast versus less than 50% bone marrow blast, you can still see that there was a significant difference within response between the two arms favoring the inotuzumab arm. And looking at the actual treatment response and proportion of patients who were MRD negative, you can see here again there was a almost 43% difference between the two arms, inotuzumab versus standard of care. And the treatment response according to the cycles, as you can see, most of the patients actually responded within the first 2 cycles for the inotuzumab arm. We'll be discussing this in subsequent slides. There's another slide just showing that, as you can see, cycle 1 42%, then an additional 38%, making a total of 80%, close to 80% responding by the cycle 2 was what we could see. After that, of course, the remaining patients slowly, there was 11% uptick on by cycle 3, but the first 2 cycles is where the gold seemed to lie. And looking at the progression-free survival also, there were significant differences between the two arms. Of course, this has been sort of abrogated in a long-term survival in the cancer paper, but we'll come to that. And the duration of remission also showed a significant difference between the two arms. Of course, this alone did not lead to curative, and this is that's why I wanted to put this slide at the end of all the the quote-unquote good news, is that finally all patients would relapse if not for a HSCT. Less than 10% patients without HSCT have a long-term survival on follow-up right now in the Innovate Long Survival arm. And as you can see here, the no HSCT versus HSCT, the only curative option as of now still remains to be this. Of course, there are the CAR T cell people will have something to say about this, but that's for another day. And coming back to our panel of experts, what is the goal of treatment in adult RR ALL in your opinion, BALL? Dr. Sudeep.
If the patient has, I mean, of a younger age group, I mean, less than 60, less than 55, I mean, that age group, the goal of the treatment would be to achieve a MRD negative response as much as possible, and then go for a transplant, preferably anything, even a match sibling or a half match, that will be there, since that is the standard of care. Through whatever method it is, I mean, given, either via Blincyto or via, I mean, I have not used Anotuzumab, but I think even that drug also, or any of the standard salvage this one, preferably MRD negative before going for a transplant. Survival is a little bit like double, although it is still less, but still double. So that is what will be my aim ultimately in patients for whom I'm able to offer that. Otherwise, it's mostly palliative. It's quite dismal.
So, Dr. Steve, from your point of view,
almost the same, only reduce get the patient into what do we say, remission, CR, along with MRD negative. That will be the ideal state. Then take them up for transplant. As doctor has said, anything is okay, like even haplo or match sibling donor, but whichever is feasible, option has to be to, if they are transplant eligible, take for transplant.
Sure. So I think the only thing that I have to add to what all of you said, which is very, I mean, I think completely true as of our current knowledge, would be that it's also a good bridge to CAR T therapy, where if we are able to get even MRD positive morphological remission, that would justify using CAR in that patient rather than, you know, with a full burden of disease. And it's a very non-toxic way to get to a CAR so that there is no overlap toxicity that may affect the CAR T therapy itself. But that is, of course, for another day, another time. As of now, HSCT is the curative approach that we, as I showed in the previous slide. Looking at MRD negativity, I think I don't have to repeat the slide again, which is essentially showing the difference between the standard of care arms in the Innovate trial. Looking at the response by a salvage status. So this is another study that came from Elias Jabbour and group at MD Anderson. And you can see here, among 164 patients treated with inotuzumab who achieved CR, 63% remained MRD negative at the end of treatment also. And the 16 patients who achieved MRD negative response were no longer MRD negative at the end of treatment in the SOC arm. So that in the salvage 2 arm. And that is important to remember because the salvage 1 response, even one cycle of inotuzumab seems to be the sufficient, especially given the cost that we are talking about, knowing that the subsequent transplant will also have to be considered from the financial aspect of view. So a single cycle seemed to be where the MD Anderson people found the maximum benefit. And the MRD negativity that was achieved in the majority of responders within the 2 cycles of inotuzumab, we've already discussed from the Innovate trial. And the median OS differences, again, that we've already discussed. The OS in patients, if MRD negativity was achieved, you can see the significant differences in OS between the 2 patients. Looking at I think an important aspect here that we should say is that there was much less adverse events in the inotuzumab arm, but we will come to that subsequently. Also, another aspect is the best treatment in first salvage and in high disease burden patients. And that is something that we discussed previously, where even in bulk bone marrow disease, where more than 50% blast load was seen, even those patients had much better response than the salvage. Back to the experts, in your opinions, what therapy is likely to yield best outcomes in adult refractory relapse BALL when offered in the first salvage? Don't take this as a loaded question. Please give your frank opinions in this regard. Sorry, we'll start with Dr. Steve.
I think for a patient who is relapsed or who is refractory to AL with standard chemo, I think immunotherapy would be the way to go, I think, nowadays, because of the accumulating toxicity of standard chemo. When we're giving a higher salvage chemo where you have more toxicity, and then subsequently the patient has to undergo transplant also as consolidation. I think nowadays, I think it will be better to go with immunotherapy. Something like if there's a bulky disease, let's say more than 50%, to go with inotuzumab, or you give some standard chemo. If they are still MRD positive, then probably with blin, make them MRD negative and take for transplant.
That's absolutely true. Dr. Sudeep? Dr. Sudeep, are you there?
Sorry, my mic was off. Yeah, regarding the best option of treatment that could be tailored according to the patient's needs and according to how much he can tolerate, and all forms of toxicity, including financial toxicity. I mean, that also to be considered before offering a salvage. Whichever is the best will be offered with an aim as per the patient's age and everything to achieve an MRD negativity. So, been using Blincyto more often. So that is also can be given. Inotuzumab would like to explore this option into the whole this field also. So that immunotherapy will be much better in that aspect compared to the standard flag, which is quite toxic, quite prolonged. I mean, the period of neutropenia. Compared to that, the immunotherapy people, at least they sail through, we can say. I mean, during the therapy.
Yeah. That's very interesting. So you're using Blincyto more, is it? How?
Blincyto in pediatric.
Okay. In the adult setting?
In the adult setting, I haven't had the chance to use that because of the fundings and all is there. For pediatric, the funding is available. So
for Blincyto, is it?
For Blincyto, not funding. I mean, crowdfunding and everything. So there has been that. So that is why we were able to use that in a few patients. But in adult, I have not yet been able to use any of these molecules.
Okay. Sure. So that's, I mean, I suppose that's interesting to get that experience from Kerala. And so, I mean, I think there's nothing more to add. I think what the Innovate trial showed and what subsequent trials and the long-term follow-up from Innovate has shown is that compared to the standard of care, inotuzumab seems to be better. But again, I just want to keep this one caveat out there, which is what the Innovate trials standard of care arm did not include hyperCVAD, did not include elevated dose or lower dose R1, R2, REZ, BFM protocol kind of salvage. So that is something that we should keep in mind and not, therefore be too swayed by saying whenever we say standard of care, it's important that we remember what the standard of care arm in the Innovate trial was. So yeah, having said that, here you can see the clear differences between the safety profiles between the two arms, that is the inotuzumab and the standard of care arm. And other than VOD, which obviously we know now is a significant toxicity of inotuzumab specifically, all other toxicities seem to be more in the standard of care arm, as you can imagine. And back to the experts, in high burden disease, does your opinion change? I mean, if I can just get a call from maybe Dr. Sudeep.
In high burden disease, we can, I think, use this one. Blincyto has been used. I mean, that has called it to a significant this one, although there needed to be a cycle of flag plus bortezomib. This was being used by a pediatric colleague, then followed by a Blincyto, and then followed by the transplant. So this was
yeah, I think you're right, because especially, I mean, comparison to inotuzumab, where it seems to you can use it at any sort of loads. I mean, of course, you have to watch out for TLS, or combine it with the mini hypercvad in the case like what they've shown in the elderly population upfront groups of ALLs. Blincyto, definitely it would be better to get the disease in some sort of modicum of control before we give it, but of course it has been used with the with the high load of blasts also. But yes, I think broadly, I think the statement stands that monoclonal antibody targeted therapy can be used even in high burden disease. And yeah, so coming to the main toxicity of sinusoidal obstruction syndrome with inotuzumab, we know that so as per the latest data, more than one cycle of inotuzumab predisposes to increased risks of VOD, which get multiplied with either a flu-based regimen in transplant, TMLI or TBI-based conditioning regimen in transplant, or if there is no use of UDCA or defibrotide-based measures that as prophylaxis or as rapid recovery therapy during the at the immediate onset of SOS. And so these were the outcomes, as you can see, between the so this is between the irrespective of the bone marrow blast count, you can see that there was a trend towards improved OS compared with the standard of care. This was across the all arms of the Innovate trial. And again, as you can see here, I mean, this is a bit of a small sample size, of course, but again, the CR patient, the CR/CRI in patients with EMD LBL were much more. And looking at the standard complications of the standard of care therapy, like febrile neutropenia, infection-related toxicities, fungal pneumonias, and sepsis, there was almost halving of all the toxicities in comparison with the inotuzumab, in comparison with the standard of care that was noticed in the inotuzumab arm, which is what this slide shows. Back to the experts, what is the long-term overall survival in your treatment setting? So you said that you were giving dismal prognosis. Currently, what would you estimate? I suppose you haven't like analyzed your data, but what is the long-term OS in your experience? And this can be across centers, maybe right from your training, right from your overall experience. If you had a patient, like 100 patients with RRALL, BALL, what would you say their long-term OS would lie in? What ballpark figure? We start with Dr. Steve.
I would say it's very dismal, maybe on 10 to 20% only for this patient, because most of the patients, when they relapse, they are not able to go for salvage therapy followed by transplant. So those patients will eventually they'll succumb to the disease. In case these patients who go for a transplant also, they have transplant-related complications which have to be overcome. They have to go into remission first of all whenever they have a relapse, and subsequently post-transplant also post-transplant complications are there. So I think maybe if you take over a period of 2 years or more, I think the percentage of patients with relapse refractory ALL will be very small, only maybe 10 to 20%, I think.
Okay, I think that lies in the ballpark of what it is worldwide with before the inotuzumab came in. And Dr. Sudeep?
It will be the same. I mean, 10 to 20% only. Interestingly, some patients with Ph positive ALL who are relapsing and still have a TKI sensitive disease. I mean, they with I mean, after a standard induction without undergoing a transplant, they are still doing okay with TKI, VCR, and the pump maintenance. We don't know how. I mean, I've seen this in the Indian settings very often in SGPGI also a few patients. So possibly having a pH positive might prove to be of some advantage in this subgroup of patients, I believe. Maybe not much of
I
a
mean,
difference, but still.
the selection bias, you leaving out the selection bias, yes, you might be right. So absolutely. And yeah, so this is the Cancer 2019 paper from Dr. Kantajan, which was looking at the long-term outcomes from the Innovate trial. Here it's important to know that, as you can see here, the figure, it's not the differences that were noticed in the first few months of the Innovate trial are not really borne out. As you can look at the two curves, the standard of care and the inotuzumab arm in blue and green respectively. And actually, the OS did not meet the pre-specified boundaries for statistical significance that was set pre-analysis. And though you could see that there was a tendency towards better OS, like 23% versus 10%, the confidence intervals were not reassuring. And so that is something to remember, that it obviously the remission does not equal cure, and definitive therapy subsequent to either inotuzumab or SOC once we reach remission is required. And this is another look at the same data where you could see the hazard ratio falling within significance as a protective effect, showing the protective effect of inotuzumab for OS. And another small question to the panelists. I mean, if you have used inotuzumab, what are the most common adverse events in your experience? And do you have any VOD experience with inotuzumab, and if there are any strategies to minimize it? Dr. Steve?
I personally have not used inotuzumab as of now, but reported side effects basically cytopenias, all anemias, leukopenia, thrombocytopenia, along with hepatotoxicity will be the main thing. And obviously VOD is also one of the, as the number of cycle increase, the chance of VOD increases. Sure. And strategies to minimize, I think we try to avoid alkylating agents whichever causes some sort of liver injury, even TBA, alkylating agents, dual alkylating regimens. And if the previously patient had previous BMT, they going for post relapse, post BMT relapse. These patients also are prone to develop VOD more things, and acetol has to be given as prophylaxis throughout, and closely look out for VOD. If it comes, then it will be treated with defibrotide.
Sure. No, so I think that's absolutely on the dot. Definitely VOD being the common side effect. That we've also noticed that some sort of cytopenias do occur, though theoretically it doesn't target HSC precursors, and it doesn't have too much off-target toxicity. We have noticed cytotox. There is a drop in counts in many of the patients after giving inotuzumab, which recovers fairly easily, of course. And regarding VOD, I had mentioned briefly that we have. I think this has been borne out in the MD Anderson ASH publications this year. I won't be talking about those specifically because there's lots of other things to talk about in the ASH 2022 updates, part of the presentation which is coming at the end. But what they also noticed was, as I mentioned, flu-based conditionings, radiation conditionings that use irradiation. More than one cycle of inotuzumab was a significant risk factor, and the lack of rapid therapy with defibrotide or the lack of using UDCA prophylactically during the use of administration of inotuzumab were all factors that showed tendency in a univariate analysis to cause increased incidence of VOD. So that's just to put that out there. And I think this is some preliminary data that has come out from the Innovate patients, and those who came out went on to the HSCT, which actually notified the world that this was an issue. And the rates of VOD, again, much more in the patients who had transplant, and despite this being more than, so there was another aspect that came out in ASH 2022, which was that patients which were within 3 months of that therapy with inotuzumab versus patients who were more than 3 months from inotuzumab, the patients who were within 3 months had a higher risk of VOD. So that's something to say. And dual alkylator versus single, any pre-existing liver damage prior to the transplant, prior history of liver disease, all this came out on multivariate analysis in the Innovate trials. And this was published actually in the Lancet Hematology by Dr. Kantajan's group again. And as you can see here, the incidence of SOS significantly increasing after cycle 1, going on to more around 20%, and by cycle 4-6 it goes on to 40%. Of course, most of our patients will never reach 4-6 cycles of inotuzumab. And the standard recommendations for prevention start off ursodiol while you're using the inotuzumab, avoiding toxic HSCT conditioning regimens. I think flu is the thing that has been added at this year's ASH as one of the risk factors, and a limit treatment to 2 cycles if going to HSCT, and of course monitoring of VOD, which is standard practice in any condition. So the penultimate section, I thought I'll just dwell on a few of the ASH 22 updates. And this will be a rapid section where I do, because there's so much to do, I focused on around 5 of the most important articles with the inotuzumab in them. And this is from a GMOL initial 1 trial. And as you can see, this is in patients patients with newly diagnosed ALL and BALL, of course, CD22 positive, 45 patients analyzed, 43 reaching the primary endpoint, and the probability of OS at 2 years being around 81% and EFS at 2 years being 73%, which is obviously very, very good data for patients with a median follow-up of 697 days in the patient group more than 55 years. So something to take note, that the trend towards movement towards upfront use of both inotuzumab and Blincyto, which was seen in this year's ASH and last year's ASH also, to be honest. And this was data from from America. This was from Ohio State University, and OS at 1 year post allo HSCT 94%, PFS 88%, with non-relapse mortality 5.5% alone. And a few of these patients going on into transplant, adult ALL, newly diagnosed. And this was patients who the specific use here was prevention of relapse post-transplant using low-dose inotuzumab at various doses. The doses that they tested were 0.3, 0.4, 0.5, and 0.6, and the limit toxicity they found was at 0.6. So they settled on using 0.5 for the majority of patients. It was a 3+3 design, and they still found fairly good. Of course, you can see something that's extremely counterintuitive in the right side figure, where they show worse progression-free survival in the MRD negative group versus better survival in the MRD positive group when using inotuzumab. Of course, this might be because of effect size issue, and obviously more data in this regard will help us understand. But it also could show that MRD positive patients who we took up MRD positive either pre or post transplant to become MRD positive, there is a significant role for inotuzumab to maintain remission in these patients. So there's that. This was a paper from the European group, EVOL-INO study, where fractionated inotuzumab with low-dose chemotherapy was used in newly diagnosed older patients. This is a study that was designed to mimic the inotuzumab mini hyper-CVAD study from MD Anderson, but they didn't use mini hyper-CVAD. They used a sort of BFM-inspired protocol, where the inotuzumab was given at 0.8, 0.5, 0.5 for induction 1, along with vincristine and steroids. And then there was, if the patient went into CR or as a salvage, the patient was given induction 2, where there were 2 doses of inotuzumab, and this time it was given with methotrexate low dose. And anthracycline was added in a few of the patients. And as you can see here, very good OS curves in comparison to the standard of care data that we know. 1 year OS 72%, 2 years OS 53.6%, with LFS 64.9% and 49.8% respectively at 1 year and 2 years. The GIMEMA trial, which is the Italian group, where they looked at IO as a bridge to HSCT and the feasibility and effectiveness. And over here, you could see that actually using 1 cycle, they used a large number of patients used only 1 cycle in this group. And around 10 out of the 39 patients, this 26% of the patients reached HSCT, HSCT possibility with inotuzumab alone. And you can see there was a significant something very, I think this is one group that has showed that they had very low rates of veno-occlusive disease. that occurred within 20 days from the last IO dose and before any HSCT. Of course, it's important to know that we would expect good VOD outcomes from an Italian group because of their experience, their large experience with the TAL and the how to manage VOD in TAL, and which probably the rest of the Western world is a bit lagging with. And another study, this is of course the big study from MD Anderson, headed by Dr. Nicholas Short, Elias Jabbour, and this is with in of course Dr. Kantajan's group. And this was the study where inotuzumab was added to hypocvat plus blinatumomab in patients with newly diagnosed BALL again. And you can of course see the almost unbelievable survival, EFS curve here, and the OS curve here, sorry, with the events, you can see here that almost 100% of the patients had no events in the hypercvat blin ino group, compared to a few more relapses in the hypercvat plus blin group. So obviously the ino seems to have, at least in this preliminary data, had a very significant effect in the EFS. Coming to the last segment of our talk, the burden of hospitalization for RRALL patients. And I think this is something that we will dwell on a bit, given that we are all practicing in the real world with patients who don't have insurance and don't have money growing from the trees. So I'll start with Dr. Sudeep. In your practice, do you find treatment of RRALL with inotuzumab cost effective compared to other treatment options when offered in first salvage in India? In your practice?
I really don't know the cost of inotuzumab, but still I would presume it's quite something. In adult patients, yes, it will be a little bit difficult at that point of time. Many of their insurance is not accepting, and the crowdfunding sources are not there. But in certain younger age groups, maybe it can still be used, where in 20 to 30, that age group, people still get crowdfunding. So also pushes us to, explore these drugs in this particular age group of patients.
So just to put it out there, it's actually it's not otherworldly costs. Anywhere between 5 to 9 lakhs is the usual regimen, especially with the PAP schemes, for one cycle of inotuzumab. So I mean, if you compare that with, say, what is your experience with the? So you would, I assume, hypercvad would be one of your salvages, or R1, R2, RZ. So what would be your cost for a hypercvad based or
hypercvad based, the cycle A and cycle B? Those will cost around, I can say, 2.5 lakhs only for the chemo initially. The cycle B will cost around 3 to 4 lakhs, maybe even more, if the patient has developed severe mucositis and everything. So that will depend upon that, being a corporate hospital. And flag IDA will cost nearly 10 to 12. That's
but as you can see, compared to a 1A, 1B hypercvad, inotuzumab isn't that bad at all.
Correct.
Especially with the PAP scheme. So that's what it is.
Cost. Yeah.
Dr. Steve, any input from your side?
So we had one patient I was planning to use. However, I think this is during the COVID time. This is a patient we were contemplating between choosing between flag, bortezomib, and inotuzumab. That time, I think, I don't know how much with the patient support program. This is a young adult, I think around 17 or 18 years. Cost came out to be around 11 lakh. That time we had calculated. So then finally we went into remission with flag bortezomib, but unfortunately he died of COVID. So it was one of those stories where we were almost planning for transplant, everything was ready, and we lost him. But however, that time maybe the cost has come down considerably, I think, according to what you're telling, because that time when we calculated it was around 10 lakhs. It was not more than that, but around 10 lakhs. Maybe I think patient support program is better. Probably then we can probably think of an option, because almost our setting also the cost will be the same only. I think if you're going for hypercvad 1A, 1B, it will be costing around 7-8 lakhs, I think, together.
Exactly.
Then the cost will be the same only, and the side effect profile will be a little bit better, definitely, when compared to hypercvad. That is one thing. And also the chances of the patient going into remission is also high. MRD negativity is also will be high when compared to standard.
Yeah, so that's something. And again, I'm going back to our favorite trial. As you can see here, 7.6 days versus 18.4 days was the hospitalization days per patient month compared to the SOCs. Again, I want to put in mind that the SOCs here were IDAC, intermediate dose cytosine, flag, and mitoxantrone methotrexate. Mitoxantrone cytosine. And so obviously you can expect this number to be way off. But still, you can see that compared to cytotoxic therapy, at least inotuzumab had very few days, and inotuzumab is easily given in an OPD basis, maybe after the first cycle to rule out any allergic reactions. It can be easily given in the OP basis. And I think I'll end there. I'd like to thank my esteemed panelists for their wisdom and their experience that they have shared. Happy to take any questions. Thank you.
Sushil sir, I have a question.
Yeah. Sure.
What is your experience with using of NAC in VOD?
So we right now we are keeping every patient post inotuzumab that is going for transplant on a prophylactic UDCA NAG protocol. We have not yet started using defibrotide, but we had lost around maybe around 4 patients post inotuzumab with VOD, intractable VOD, which really came on too fast for anything. And so we've now made a new protocol to add defibrotide as a backup, especially after this year's ASH update, the posters that came out. But definitely NAC has a role to play, and we are using it in real world right now for any patient post inotuzumab with a hint of VOD and as prophylaxis in the transplant setting post inotuzumab.
So quite cost effective also. That's
Yes,
what I found when
definitely.
using it throughout the conditioning and also.
Definitely.
Hello, Street.
Tell me.
These patients on when you give inotuzumab, what are the things? How do you monitor? Do you have a protocol for looking at VOD? What are the things you look at basically?
So it's very similar to our VOD monitoring of TAL. So that's the good thing about it is that we have a TAL experience here at Vellore. So we are very tuned to picking up VOD at a very early stage. Because that's what we do in our TAL patients. We are doing all literally 3 high risk, Vellore high risk patients. And so that same attitude is what we take for any inotuzumab. It's essentially just looking better. So in the same setting, any weight gain more than 10%, any increase in liver size, especially if there's a tenderness involved with the liver, even if there's a tenderness without an increase in liver size, if there's any intake output variations that are not explained, anything that gives us an inkling that this patient is going down that path, we immediately start monitoring better, start on dopamine infusions, start on Lasix infusions to control fluid intake outputs and to better perfuse the kidney and the splanchnic circulation. And of course NAC, as I had mentioned before. And the thing that we have not yet started to do, which we are going to start to do, is defibrotide in those patients who can afford. And one thing that recently we started to do is move away from so we actually, the last inotuzumab patient that we are treating, we've actually not given a TMLI or TBI based protocol purely because the patient was on was a post inotuzumab. So we are actually giving flu-bu for that patient rather than Cy-TMLI or Cy-TBI. So that's an interesting change. Observation that we have started doing. But hopefully we will stick to the TMLI-based protocols, but with better prophylaxis in the future. We had quite losing those 4 patients was not a good thing because it was something that we didn't want to. We thought we could keep in control, but it's just it comes on as bad as any of the TAL VODs which are refractory. It doesn't reverse despite best therapy that we know. So
thank you.
Your experience with non-TBI based regimens in ALL, sir. So because trying to prevent VOD, one of the contributory factors.
No, so we go always with, we always prefer TMLI. So we use TMLI here. We've moved from TBI to TMLI. That, but even the TMLI based, so the of those 4 patients that passed away, 3 of them had a TMLI regimen, and despite that, So our with consulting with our radiation department, they've taken a lower radiation dose in the TMLI protocol to the liver bed. That's something that they changed. But we are, I mean, as of now, I mean, if you're asking in context with inotuzumab, that's our experience. But in the past, we have used Flubu for many of the patients where TMLI is either not a viable option, especially in patients who are not fit for, in pediatric patients not fit for anesthesia. Those are the usual settings where we end up giving more, standard myeloablative conditioning without radiation. So I mean, if the specific question I can help, but in our broad experience, the patients with flu-bu do in ALL, their outcomes weren't. Of course, we have very few numbers compared to our SITB, SITMLI, but the outcomes weren't too adverse in comparison to them. So it is definitely a viable protocol, and there is anyway published data on flu-bu in ALL. So it's definitely something that can be used.
Thank you.
Yeah, if there are no other questions, I think we will conclude the session. Is it okay? Yeah. Yeah, good evening, doctors. I'm Sujit, Regional Head for Pfizer. So thank Dr. Sushil for taking up this great moderation, more interactive one. It's almost 1 hour the discussion has gone on. And I would also take this opportunity for Dr. Steve and Dr. Sudeep for sharing their in-clinic insights and sharing the feedbacks and your expert opinions as well. So as Pfizer, we are privileged to be part of such meetings, and we would look forward for such academic and closed group meetings where a lot of experience are shared and it's more interactive. And thank you once again, all, for taking time in this evening after your busy schedule and coming for this academic fest. Thanks once again, doctors. Thanks a lot.
Thank you.
Thank
Bye,
you.
Steve. Bye, Dr.
Thank you.
Bye, Dr. Sudeep, Dr. Steve.
Bye, Dr. C.
Bye, yeah.